Hello everyone in CardioMinds channel, and we are speaking today about one of the most common causes of ventricular arrhythmias, which is coronary artery disease. Let's emphasize some facts that sudden cardiac death is closely related to coronary artery disease, which is responsible for 75 to 80% of cases of sudden cardiac death. And still, coronary artery disease represents a major cause of sudden cardiac death starting from the fourth decade. That's why in any adult with VT, coronary artery disease is still the first possibility to be excluded. As we see in this famous diagram, that the age of presentation of ventricular arrhythmias in patients with coronary artery disease usually starts from the age of 30s, which is the fourth decade. In acute coronary syndrome, the dominant type of ventricular arrhythmia is polymorphic VT, whereas in chronic coronary artery disease, famously known as chronic coronary syndrome, the dominant type is monomorphic VT. We divide our coronary artery disease patients in this video today into those with acute coronary syndrome, patients with coronary vasospasm, patient in the stage early after MI, patient with chronic coronary syndrome, and those with coronary anomalies. Let's start with acute coronary syndrome. Let's elaborate other facts. That sudden cardiac death is a major cause of mortality in acute coronary syndrome, which is mostly caused by sustained ventricular arrhythmias, especially VF, and 4 to 12% of STEMI patients can develop ventricular arrhythmia within the first 48 hours after the onset of symptoms, and we call this period of electrical instability, in which it is common to develop ventricular arrhythmia even after reperfusion. And of course, pre-reperfusion ventricular arrhythmias are more common than reperfusion-induced or post-reperfusion arrhythmias in STEMI. So reperfusion reduces the incidence of ventricular arrhythmia, but still it can occur. And the independent predictors for developing ventricular arrhythmias in STEMI or non-STEMI patients are the hemodynamic instability, cardiogenic shock, so those patients are more liable for ventricular arrhythmias, LV ejection fraction less than 40%, the sum of ST segment deviations in all ECG leads, so the higher the sum, the higher the risk for ventricular arrhythmias, and failed reperfusion is a strong risk factor for ventricular arrhythmias. So how to prevent ventricular arrhythmias in patients with acute coronary syndrome? Urgent reperfusion is the most important line of treatment, and we know that acute ischemia triggers arrhythmias, and successful reperfusion reduces the incidence, plus beta blockers, which can reduce the incidence of ventricular arrhythmias, and correcting any electrolyte imbalance. In this randomized controlled trials, the early intravenous beta blockers in patients with STEMI before primary PCI was compared to placebo, and the safety endpoints in which we stop or avoid IV beta blockers is symptomatic bradycardia, symptomatic hypotension, or cardiogenic shock. The result here is that early IV metoprolol before primary PCI in STEMI patients reduce the incidence of ventricular arrhythmias in the acute phase without any increase in adverse events and without also reducing infarct size, so the intravenous beta blockers, unless contraindicated, are beneficial in STEMI patients. And remember that there is no role for any prophylactic antiarrhythmics like amiodarone or lidocaine, as they are only used for treatment. And if the patient developed ventricular arrhythmia, so electrical cardioversion for VT or defibrillation for VF is the first line of treatment. And if the patient is having recurrent sustained VT or VF, so we should think of immediate coronary angiography even if the patient already had primary PCI, because here the ventricular arrhythmias may indicate incomplete reperfusion or recurrence of acute ischemia due to, for example, stent thrombosis, and IV beta blockers and IV amiodarone should be started. Lidocaine may be used if the treatment with beta blockers and amiodarone is not effective, and we may need deep sedation plus minus mechanical circulatory support for hemodynamically unstable patients with refractory ventricular arrhythmia. So the recommendation here is that intravenous beta blocker is class 1 indication for patients with recurrent polymorphic VT or VF unless contraindicated, like acute heart failure, hemodynamic instability, bradycardia, or AV block, and intravenous amiodarone is a class 2A for those patients. Lidocaine is class 2B if the amiodarone and beta blockers are not effective or there is a contraindication, and the big no that the prophylactic treatment with antiarrhythmics other than beta blockers is not recommended. They are only used for treatment. Let's move to coronary vasospasm, elaborating some facts that patients with life-threatening ventricular arrhythmias secondary to coronary vasospasm are at high risk for recurrence, especially if there is insufficient medical therapy was administered. And beware that beta blockers are contraindicated as it may trigger coronary vasospasm due to unopposed alpha receptor stimulation, so increasing the incidence of ventricular arrhythmias. So the treatment here is for calcium channel blockers, which are effective in suppressing these episodes plus minus nitrates, and ICD should still be considered in survivors of sudden cardiac arrest with variant angina assumed to be due to coronary vasospasm. So what raised suspicion for coronary vasospasm? Presence of a typical chest pain by history taking with ST segment deviation during the pain, mostly ST elevation, and non-obstructive coronary arteries, so we should suspect coronary vasospasm. The clear recommendation here is that patient with coronary spasm and survivor of sudden cardiac arrest ICD implantation should be considered as class 2A. There is a common situation that some patients may have ventricular arrhythmias in the early stage after MI. We divide this stage into two types: early ventricular arrhythmias occurring in the first 48 hours after STEMI, and late arrhythmias occurring more than 48 hours after STEMI. The early arrhythmias here almost occur within the first 24 hours because of the primary PCI, which is nearly the sole treatment at the time being for STEMI apart from thrombolytics, but still extend this period to 48 hours. It is associated with six-fold increase in the in-hospital mortality, whereas long-term prognosis is not significantly affected. And in a prospective cohort study, the patients with VF during the acute phase, even after successful primary PCI, had similar incidence of late sudden cardiac death compared with VF-free patients during 5-year observation. But regarding the late ventricular arrhythmias, the long-term all-cause mortality after STEMI was predicted by occurrence of ventricular arrhythmias late after reperfusion, and so further studies are required to clarify the impact of these types of arrhythmia on late sudden cardiac death. So the early arrhythmias are usually correlated with in-hospital mortality, while the late arrhythmias usually correlated with long-term mortality. Regarding the risk stratification, of course, it is a routine practice to have early assessment of LV ejection fraction before discharge in all patients with acute MI, and if the ejection fraction is less than 40, we should re-evaluate it after 6 to 12 weeks after MI, which is usually 1.5 months till 3 months, to assess the potential need for primary prevention ICD implantation. And the early assessment by further non-invasive tests apart from LV ejection fraction has not been proven to be useful for risk stratification so far. If the patient is having recurrent episodes of polymorphic VT or VF in the early stage after MI triggered by a similar PVC not responding to medical treatment or coronary revascularization, so catheter ablation here is class 2A, but after you exclude ischemia and after starting beta blockers and amiodarone at the highest tolerated doses plus minus kinidine, that may be beneficial. So in presence of electrical storm, we should go for catheter ablation after excluding ischemia and starting medical treatment. And the big no, which was published in the 2021 guidelines of heart failure, that ICD is not recommended as primary prevention within the first 40 days after MI, as here it does not improve prognosis as shown in the Dynamite and IRIS studies. So in patients with STEMI, IV beta blockers before PCI should be considered. If not contraindicated, then go for urgent coronary angiography and revascularization. If the patient developed ventricular arrhythmias, so further revascularization if appropriate. Check electrolytes and correct any imbalance accordingly. Start IV beta blockers and sedation may be beneficial. The patient is still having recurrent ventricular arrhythmias. Start amiodarone plus minus lidocaine, and deep sedation and intubation may be needed. Still recurrent, of course, go for catheter ablation as class 2A. Overdrive pacing may be beneficial. Autonomic modulation and mechanical circulatory support in refractory cases. The main bulk of our video today is speaking about patients with chronic coronary syndrome. Reminding ourselves with the 2021 guidelines of heart failure. This video was published a few months ago regarding the role of ICD in patients with heart failure with reduced ejection fraction. It was published in CardioMinds channel in English and Arabic versions, so I advise you to listen to this video before going in depth with the role of ICD in chronic coronary syndrome. The primary prevention in the 2021 guidelines was indicated to reduce the risk of sudden death and all-cause mortality in patients with symptomatic heart failure, NIA class 2 to 3, ischemic etiology, unless they have had MI in the first 40 days after MI, because there is no benefit, and ejection fraction less than or equal 35%, despite 3 months or more of optimized medical treatment, provided that they are expected to survive substantially longer than 1 year with good functional status, and here it is class 1 ischemic LV dysfunction. And the same purpose and same conditions in patients with non-ischemic etiology, but here it is class 2A rather than class 1. What about the 2022 guidelines of ventricular arrhythmias? Is there a difference? The risk stratification and primary prevention of sudden cardiac death here has the same indication for ICD for primary prevention, so there is no great difference. But there is an additional recommendation for those with severely impaired ejection fraction less than or equal 30%, even if they are in NIHA class 1. Despite 3 months or more of optimized medical treatment, we can go for ICD, and it is class 2A. So this is an additional recommendation to put an ICD. If the patient is having ejection fraction less than or equal 40% despite 3 months of optimized medical treatment, and the patient develops non-sustained VT, and then we had EP study with inducible sustained monomorphic VT after programmed electrical stimulation, so this patient is indicated here for ICD implantation. So we are going for programmed electrical stimulation during EP study. If the patient had inducible VT, go for ICD. The patient has no inducible VT, so there is no need for ICD. So we don't go directly for ICD implantation in those patient population. And the same big no in chronic coronary syndrome, no role for prophylactic treatment with antiarrhythmics other than beta blockers. And please remember, before thinking of ICD implantation, you should adopt early revascularization strategy to exclude any ongoing ischemia and treat it, and of course optimize the medical treatment before going for ICD. What about patients with heart failure with mildly reduced or preserved ejection fraction? So far, there are no data supporting primary prophylactic ICD implantation in post-MI patients with preserved ejection fraction more than or equal 50% or mildly reduced ejection fraction between 41 to 49. So in those patients, if they develop unexplained syncope after non-invasive evaluation, programmed electrical stimulation here is recommended to guide patient management in order to decide whether this patient would benefit from ICD or not, provided that there is no clear indication for primary prevention, as here the ejection fraction is more than 35. So we are also following the previous recommendation to perform programmed electrical stimulation. If there is inducible VT, go for ICD. No inducible VT, no indication for ICD. Regarding the secondary prevention, in the 2021 guidelines for heart failure, it was indicated also to reduce the risk of sudden death and all-cause mortality in patients who recovered from a ventricular arrhythmia causing hemodynamic instability like documented VF or hemodynamically not tolerated VT, who are expected to survive more than 1 year with good functional status in the absence of reversible causes or unless the ventricular arrhythmia has occurred in the first 48 hours electrical instability periods after MI. So this is a clear indication for secondary prevention in the 2021. What about the 2022 guidelines? Is there a difference? It is nearly the same recommendations that ICD is recommended in patients without ongoing ischemia with documented VF or hemodynamically not tolerated VT occurring later than 48 hours after MI, so it is nearly the same as in 2021 ESC guidelines of heart failure. What about if the patient was having well-tolerated sustained monomorphic VT? Is he still indicated for ICD as a patient with hemodynamically not tolerated VT or VF? We remember these recommendations that we mentioned previously. The patient with ejection fraction less than 40 despite 3 months of optimized medical treatment and still having non-sustained VT, we go for EP study to check whether there is inducible VT by programmed electrical stimulation, and if it is inducible, go for ICD. So, if the patient is having spontaneous VT without any induction by EP study, so he is still indicated for ICD. So in those patients, is class 2A to go for ICD if he is having hemodynamically well-tolerated sustained monomorphic VT. But if the patient is having hemodynamically well-tolerated VT and ejection fraction more than 40%, so catheter ablation here is indicated to be performed in experienced centers as an alternative to ICD to reduce further VT episodes, and ICD should be considered if the ablation failed or it is not available or not desired as an alternative to ablation. And put in your mind that catheter ablation prevents further VT attacks, whereas ICD just detects and treats new VT attacks without preventing them. So in order to tailor the appropriate treatment strategy, think of the aim of each one of those treatment lines. If the patient is having recurrent sustained monomorphic VT, so we should add oral amiodarone or replace the conventional beta blockers by sotalol in order to reduce the symptomatic VT episodes or reduce ICD shocks in patients with already implanted ICD. If the patient is still having recurrent symptomatic sustained monomorphic VT or ICD shocks for VT despite chronic amiodarone therapy, so catheter ablation here is class 1 in preference to escalating antiarrhythmic drug therapy. And we have here the VANISH trial in which the composite endpoint of death, VT storm, and appropriate ICD therapy was reached significantly less in the ablation group as compared to the escalated amiodarone therapy group over a median follow-up period of 28 months. And still the same indication, but with class 2A if the patient is having recurrent VT or ICD shocks despite beta blockers or sotalol, so without starting amiodarone therapy, catheter ablation is class 2A. There is a controversy about the role of ablation before strictly indicated ICD. The patient with coronary artery disease who are eligible for ICD implantation, catheter ablation may be considered just before or immediately after ICD implantation to decrease subsequent VT burden and ICD shocks, because as we mentioned, ICD does not prevent further attacks, but catheter ablation can prevent. In the Berlin VT study, the preventive VT ablation after the first documented VT before ICD implantation did not reduce mortality or hospitalization for arrhythmia or worsening heart failure during 1 year follow-up compared with the deferred ablation strategy. That's why the evidence here is weak. It is class 2B. However, ablation here can decrease subsequent VT and ICD shocks. That's why some physicians may consider this approach, although there is weak evidence, but may be intensified in the future by further clinical studies. And remember that sustained monomorphic VT is rarely caused by ischemia because mostly here it is scar-related re-entry, and so revascularization alone does not prevent VT recurrence, but should exclude or treat significant coronary artery disease before catheter ablation, which is a reasonable treatment approach. So in this diagram regarding patients with chronic coronary artery disease, we should, as we mentioned, evaluate ejection fraction 6 to 12 weeks after acute MI if the pre-discharge echo showed ejection fraction less than or equal 40%. If the ejection fraction is less than 35% and the patient has NIHA class 2 or 3, so go for ICD. But if the ejection fraction less than 30%, in this case, we can go for ICD as class 2A even if the patient is in NIHA class 1. If the patient is having ejection fraction between 36 to 40% and he is having non-sustained VT or unexplained syncope, go for programmed electrical stimulation using AP study. If he had sustained monomorphic VT inducible, go for ICD. No VT inducible and still having unexplained syncope, go for implantable group recorder. Otherwise, if there is no non-sustained VT, just follow up. If the patient already developed sustained monomorphic VT, if it is a first presentation and ejection fraction more than or equal 40%, check the hemodynamic status of the VT. If it was well tolerated, so go for catheter ablation. ICD implantation here can be an alternative treatment if ablation was not available, not successful, or not desired, and amiodarone here is an essential line of treatment. If the ejection fraction was less than 40%, so go for ICD because here the patient is indicated for prevention by ICD. Catheter ablation here is class 2B to be performed before or immediately after ICD implantation. If the patient is already an ICD carrier and he is having electrical storm, so we are managing it according to what we mentioned in the video of acute therapy of ventricular arrhythmias, and I am putting a link for this video here. If the patient is having symptomatic sustained monomorphic VT and he is on amiodarone, so go for catheter ablation. Not on amiodarone, just on beta blockers. We can replace the conventional beta blockers by sotalol. Catheter ablation here is class 2A without starting amiodarone, and of course it is appropriate to start amiodarone if not contraindicated. And the last topic we are going to speak about today is the coronary anomalies. The anomalous origin of left main coronary or right coronary artery from the opposite sinus of Valsalva is associated with an increased risk of sudden cardiac death, especially in individuals less than 35 years during or following vigorous exercise. That's why coronary anomalies is one of the commonest causes of sudden cardiac death during exercise. And the anomalous origin of left coronary is less common but more malignant. And what are the risk factors here for sudden cardiac death? Because not all the coronary anomalies are the same. The interarterial course of the coronary between aorta and pulmonary artery, which is common for the left main coronary artery, slit-shaped orifice, which contribute to the exercise-induced ischemia, high orifice of the coronary artery, acute angle takeoff, and intramural course, including its length. So all these factors contribute to much more ischemia and so higher risk of sudden cardiac death. The gold standard test is the CT coronary angiography to evaluate the high-risk anatomy, so determining the type of the anomaly and whether there are any high-risk features or not. After CT coronaries, we have a role for cardiac stress imaging during exercise in addition to cardiopulmonary exercise test in those with anomalous aortic origin with an interarterial course to confirm or exclude ischemia. And the cardiac stress imaging during exercise is also recommended after surgery in patients with anomalous origin of a coronary artery with a history of aborted cardiac arrest. So how we treat a patient with confirmed coronary anomaly? Surgery is the first line of treatment in those with syncope suspected to be due to ventricular arrhythmias or angina when other causes have been excluded and is class 1 indication, and in asymptomatic patient with anomalous origin and evidence of myocardial ischemia or abnormal aortic origin of the left coronary artery with high risk features surgery is class 2A to avoid the risk of sudden cardiac arrest. So we have reached the end of our video today, and our take-home message is that when you deal with a ventricular arrhythmia in a coronary artery disease patient, first exclude ongoing ischemia and exclude electrolyte imbalances. If these reversible factors are excluded, so think of catheter ablation to prevent further attacks and or think of ICD to treat further attacks according to the clinical scenario, the LV ejection fraction and risk of sudden cardiac death. We can decide which of them is the appropriate line, or we are going to need both of them. And remember, don't miss coronary anomalies as a cause of sudden cardiac death in young individuals, and of course it can be diagnosed by CT coronary angiography. And don't miss coronary vasospasm as a cause of sudden cardiac death in young and middle-aged individuals by presence of typical chest pain with ST changes and non-obstructive coronaries. Thank you very much for watching this video, and wait next week for another specific disease responsible for ventricular arrhythmias.